We are live.
Okay. A very good afternoon to each one of you. At the outset, I'd like to thank AI Scientific Committee for giving this wonderful opportunity to us to conduct this video assisted certification course, OPMS, One Problem, Many Solution. So today it's module 7. And okay, so Namrata ma'am is here, our chairman scientific committee. Welcome, Namrata ma'am. Ma'am,
Oh,
yeah, we are waiting for you,
so
ma'am. Please.
welcome everyone, the delegates as well as the faculty for this course again. And I would again like to thank Harshul for it's become so famous now. Everybody says OPMS is doing very well. So it is one problem, many solutions. And thank you, Harshul, for coordinating it. And I'm sure again we are going to have a great course with such illustrious speakers. And I think we have 900 plus registrations already for this course. And of course, you can download your certificate after you do those questions. And we are running it in many modules, and the certificates will be given at the end of the course. So thank you everybody for joining, and over to you, Harshul, for the course.
Thank you so much, ma'am. So today it's module 7 on Phaco in pseudoexfoliation and loose zonules. That's a real big problem which every Phaco surgeon faces. So today we have moderator for this session, Dr. Sunandini Bose and Dr. Shivani Patnaik, who will be moderating the entire session. Thank you so much for doing all the work. And we have amazing speakers today, Dr. Sajad Fazli from Srinagar, a prolific anti-segment surgeon. We have Dr. Rakesh Shakia from Chitrakoot. We have Dr. Ellen Kumaran from Bangalore and Dr. Shivani Patnaik from Mumbai. And thanks to our expert panel, Dr. Pankaj Sharma, who is my teacher and who is senior professor in SMS Medical College, Jaipur. Dr. Satyajit Sinha, who we all know is from Patna, Secretary of Bihar Ophthalmic Society, who is doing amazing work, who is here with us. We have Dr. Dilip Lalwani, who is a prolific cataract and glaucoma surgeon from Chhattisgarh, is Chairman Scientific Committee. We have Dr. Shikha Bassi from Shankar Nitalia. So I welcome you all for this session and I hand over to moderators Dr. Shivani and Dr. Sunandini.
So good afternoon, everybody. I'm Dr.
Dr.
Shivani. Hello, am I audible?
Dr. Sunandini, can you introduce? Yes, yes.
Yes, sir. So I welcome you all to this module number 7, where we are going to discuss about the pseudoexfoliation and the loose zonules phacoemulsification in these difficult cases. And I welcome our first speaker, Dr. Shivani Patnaik. I'm just quickly going to share my screen for the CV, please. So Dr. Shivani is currently a consultant at Proctora Institute, and she has won numerous awards and scientific papers and Best Video Award in AISC. She has also won the Grand Prizes and Grand Video Honors in 3 years in row in IIRSI, and she has authored a chapter in Oculus Rus Gesto. She has also co-produced winning scientific films at the ACRS Congress, and she has co-produced a winning film at AIC APAO this year, which has won the Dr. C.S. Reshmi honors. And with this, I invite Dr. Shivani to kindly share her screen and give the first talk on overview of problems of pseudoexfoliation. Dr. Shivani, to you, please.
Hello, am I audible? The signal is a little shaky.
Yes, you are. Yes, you are.
Okay. Good afternoon, everybody. I'm very thankful to Dr. Namrata ma'am and Dr. Harshul sir for thinking of me for moderating this session with such esteemed faculty. I'm very excited to present in this course and to moderate it. Thank you, Dr. Sunandini, for this wonderful introduction. I'm overwhelmed. So, a little bit about what we are going to discuss today. I'm just going to share my screen so that we can start with the first talk. Uh, I'm joined by such session is, I mean, it's an honor because this is a very less talked about topic because it's a very common topic. So people think that yes, of course, we have solution one, solution two to tackle pseudoexfoliation, but every time it's like a Pandora's box. So it opens up and we don't know what to do with it. So I'm just going to give a quick overview and then I'm going to tell what our other speakers of the day are going to talk about. So let me just start with the session. I hope my screen is visible. Please let me know if there is any issue. Yeah. So it's pseudoexfoliation, but the problems are real. So these small flakes which we see on our patient's anterior capsule and stuck to the pupillary margin, they have big surgical consequences. I would always, as always, like to thank my mentor, Dr. Kumar. Doctor has taught me so much about this topic and beyond. Moving on. So what is pseudoexfoliation? Just a short, these are fibrillar extra eye reduce angle everywhere, and they look like peel off. So now this area only the is not where we have to consider. We have to look at systemic conditions which are associated with this and ocular manifestations. It is associated with secondary glaucoma, very, very common, and it is not just a lens problem, it is a zonular disease. Important to know here is that when we look at a patient like this, we have to immediately get 4 or 5 points in our head so that we can plan ahead, plan better, and our OT can become safer. So these clinical signs are something that we should not miss. There's a very typical bullseye pattern or a three-zone pattern on the anterior capsule, as you can see in the image. There are pseudoexfoliation deposits, then a clear zone, then deposits, and then again a clear zone with the deposits back again, making a ring pattern of pseudoexfoliation. These patients have poor pupillary dilatation. Especially in such patients, we should always consider whoever has poor pupillary dilatation, we should always keep in mind that maybe they have zonular distress as well. Maybe they may have dialysis or the zonules may be weak. Pseudoexfoliation material is found in, and pigment is found in the angle of these patients. So we have to examine, do a gonioscopy and see. Sometimes the phacodonesis may not be very obvious, but it is present. Iridodonesis is present. Phacodonesis may not be present, but the lens may be tilted, which we will find only on gonioscopy. So it's important not to miss that. Endothelial compromise, yes, in advanced cases, we do get patients who are having a poor endothelium. Specular microscopy is important in such cases. These things are not only important for documentation, but also to plan your surgery better so that you can use better solution and viscoprotective, endothelium protective viscoelastic, and you can choose a good BSS solution so that you don't harm the endothelium, so that your chamber maintains without harming the endothelium and without losing the lens. Now, why cataract surgery is high risk in pseudoexfoliation? This topic is so much discussed, but every time in the OT, it's like a new challenge. So we should know that zonules are fragile. That affects us right from the beginning, right from creating a capsulorhexis where we see those indulations or the folds, which are not allowing us to make a proper rhexis. A good around 4 to 4.5 millimeter or 5 millimeter rhexis should be made, I feel. And small pupil complicates the surgical maneuvers. Always think when you should use pupil expanders. Don't shy away from using any pupil expanders that you may have, because the pupil is going to come down and it is going to create complications in the cataract extraction, as well as your examination of the rest of the bag, so that if there's any zonular dialysis, it should not get missed. Greater postoperative inflammation is possible in such patients and higher chance of late IOL decentration, as we can see in the image. The IOL bag complex itself has decentered. This is also possible. Keeping a track of such patients is very important. Preoperative planning pearls, we assume zonular weakness and poor dilation. This is because we know that the rubbing of the zonules also, the rubbing of the iris structure also causes a pigment dispersion. So we should know that such patients may have a very close contact of the iris and the anterior lens capsule. Counseling patients, very, very important. Give that extra chair time. We should know that such patients expect 6/6 vision. They expect one sitting surgery. But the things that can go wrong, obviously not to overwhelm the patient. And I believe that in this session, we are going to learn more and more on about how to counsel such patients, as well as how to manage these cases in surgery so you get the best operative outcome. Keep your devices ready. Always keep your table ready with CTR, with extra hooks, iris hooks, capsular hooks, devices, and make sure that you're not falling short of anything. Prepare so that you don't panic in the OT and the patient doesn't panic post-op. Intraoperative strategy, I would aim for a larger capsulorhexis, gentle and multi-quadrant hydrodissection, minimize nuclear rotation. All these are to prevent and protect the zonules, and perform phaco in low settings and low fluidics so that you're not stressing the bag and the zonules. also not causing us pupillary meiosis intraop. That also helps. Intraoperative red flags where we have to stop and assess. Capsular striae that we see during CCC creation, lens wobbling or instability, uneven chamber depth, sudden pupil constriction, and difficulty in rotating the nucleus. These are first that you should remember. Any of these red flags that you're getting, then you have to immediately stop and assess. So what I would suggest, and from my side, from the little experience that I have, is to monitor early IOP spikes in such post-op cases, watch for capsular phimosis post-op, and a long-term follow-up to check if the IOL is still centered or is there a decentration. Such eyes need a little closer surveillance, but I believe that the most important part is to diagnose early, to prepare before you take into the OT, and to counsel the patient regarding what the outcome could be. So this is what I wanted to give as an overview of what we might be learning in this session from our elite faculty. I would like to invite the next speaker. If there are
Dr. Shivani,
anything that you would like to
we
say.
can take the expert, yeah, we can take the
Yeah.
expert panel discussion first with Dr. Shikha
Yes.
Basi. Ma'am, are
Yes.
you there?
Okay.
Yes, I think, ma'am, Dr. Shivani has done a wonderful job in making it an exam viewpoint. I think it is going to help our residents a lot. And we would like to discuss, ma'am, that what do you think that when a resident or a young ophthalmologist who is starting to do a pseudoexfoliation cases at the very start, what are the opinions or what are the clinical signs you would say that they must be, seeing in these cases?
Yeah.
If you
Very,
can elaborate.
yeah, at the outset, really well presented, Dr. Shivani. Your overview was very nicely presented, and she's already told the answers in her talk that what one should look for when one's taking this case of pseudo exfoliation. Uh, if you see poor pupillary dilatation with this whitish deposit at the pupillary margin, you know that you're dealing with pseudoexfoliation. Now, for your exams only, why is it called pseudoexfoliation? Because there's something called true exfoliation also, which is seen in glass blowers, where the anterior lens capsule is delaminated. That is very rare. That is in particular situation. Most of the time, when you see flaky material in the anterior chamber, that is at the pupillary margin, on the pupillary surface, or also in the angles, these patients can have increased intraocular pressure preoperatively or postoperatively. You might have to monitor. Now, in these situations, what one must be prepared for, if this is your first or second case and you have a patient of pseudoexfoliation, you know intraoperatively this pupil is not going to dilate that well. And because of that, if you don't dilate, you've used your intracameral drugs, it's not going to dilate this pupil. So it will be, wise to dilate the pupil using either hooks or other devices, rings, dilate so that you get a proper capsulorhexis. Now, in these patients, if it's a borderline pupillary dilatation, what one might think that, I can get away with the Phaco. But in the initial cases, it's very important to get a proper rhexis, because if you are not able to see the rhexis margin and it's just at the margin of the pupil, you can land with more complications. Because what are the complications that you can have? You can have it when you're doing your irrigation aspect at every step, hydrodissection itself, these patients, you can have a chance of, the extension of the capsular rhexis. And when you're doing phaco, you might damage again the capsule. And the commonest problem occurs when you're doing your irrigation aspiration, where you can land up with dialysis, localized dialysis. In pseudo exfoliation, the weakness of the main problem that you have to be wary of is that there will be segmental zonular weakness, which will be asymmetric between both the eyes, and in the entire all around 360 degrees parts. Maybe it will be an unstable bag on which you will be operating. So, one, you dilate your pupil with hooks or rings or whatever, and do
did say, Dr. Shivani did say that you don't do a one gel spray of capsule of hydrodissection. You do it in multiple parts all around. But at the same time, when you're rotating, be sure that it's a free nucleus that you're rotating. If you try and push at both the places, when you're doing your capsular rexus, don't try and push, because that's going to tear that those weak zonules further. And when you're rotating your nucleus at that time also, be sure that the nucleus is free. And during phaco also, everything has to be gentle. During, if you notice any weakness of these zonules, if you notice that you've already there is, dialysis that has occurred, then you have to tamponade that area with viscoelastic. If you have dispersive viscoelastic, and put the CTR. I think we can discuss further as we go.
Thank you so much, Dr. Shikha ma'am. I think it was wonderful to hear Dr. Shivani and Dr. Shikha ma'am give their all opinions about managing these cases of pseudoexfoliation. I now hand over the mic to Dr. Shivani. She is going to introduce our next speaker. Dr. Shivani, to you, please.
Thank you, Sunandini. Thank you so much for the great comments regarding my talk. I would like to take this session further and learn to know what our esteemed faculty have to say about this. I would like to quickly introduce our next speaker, Dr. Sajjad. I'm sharing my screen. Is my screen visible?
It's coming a little partial.
That's okay.
So I'm introducing Dr. Sajjad Fazili. He is from uh, Paradise on Earth, Kashmir, Srinagar. He has performed more than 50,000 phaco surgeries. He's a pioneer in Jammu and Kashmir for phaco emulsification and cataract, pioneer in refractive surgery, and the recipient of the coveted IRSI Gold Medal. He has received the Award of Excellence also from the ICRS. He's our very esteemed national and international faculty who is going to share with us his top pearls on cataract surgery and phaco emulsification. We look forward to learning so much from you, sir. Please take over. Thank you.
Am I audible?
Yes, you are audible.
Okay. Now, pseudoexfoliation, like Dr. Shivani told us, we can have signs and we can have an assessment, because whenever we are embarking on a surgery in a slightly difficult case, we should know what we should be doing. Here, the situation is different. Here, we are talking about the possibilities that can occur and whether we are ready for them or not. So we'll be talking about zonulopathy and pseudoexfoliation. You see, this case, straightforward case, we know there's pseudoexfoliation here. Looks okay. All the time we are trying to look at the capsule, watching the lens, whether it's putting an air bubble for trap and blue or whether it's for anything else. You are constantly watching this lens, you're watching the AC. Never overinflate before a capsular excess. And capsular excess is the time when you actually assess how much the zonulopathy is there. Here we're seeing there's not much problem, and a good flap has been lifted. And throughout the capsular axis, we don't see any problem. It's progressing nicely. We have to remember then that in pseudoexfoliation, because there is no, the zonules are weak sometimes, what happens is that this does not progress as easily. Then we see the capsular axis happen nicely. We are again watching the lens. We did a gentle hydro because there is some subcapsular fibrosis also here, but we can see that reasonably okay, a little bit of movement there. But I seriously thought that I might be able to do a good phaco. You can see that slight um, bulge of the um, capsular axis margin. I go in, I go and get into a chop and I divide nicely, and everything seems to be okay. And then I just try to move this and hold this, and you can see I was just trying to hold. I didn't want to completely rotate the lens, but I wanted to hold it, and you could see that there was a sector, one side of the zonules which were weak, and the lens started coming up. Now I'm sure. Now it's the time to retrieve the situation, and I'm putting capsular hooks on the capsular margin so that the bag becomes stabilized. One, two, but one has to also understand that zonular weakness, when it is there, it's more or less generalized, or it can occur in sectors. I'm not ready to take a chance here. I'm putting capsule hooks all around, not in that sector where I was, not in that area where I felt the zonular weakness was. And now that my bag is stabilized, this is going to give anterior support, hold it like this, but it's not going to give equatorial stability. So I'm putting in a CTR ring before I attempt any more nucleotomy. The chop is the best technique for such patients because it puts the least amount of stress on zonules. Also, important to remember is that you have to slow down now. You have to bring down your irrigation, or if it's a higher system, you have to bring down the IOP, work on a lower IOP, and you have to move slowly. There's no question of rushing through this, because if you are trying to rush, you might cause more problems and then you land up in a problem. You can see even at the last piece, I'm very, very slow. Also important to remember that once the CTR is there, there is a problem with IA, but generally speaking, that is something that can be circumvented. The IOL is implanted and viscoelastic is removed. Viscoelastic can be even removed after that, but if you are seriously thinking that the irrigation bottle, the fluid going in might again jeopardize, then most probably only a CTR and rings were not enough, then you needed to do more. This is another case you see, um, the pupil size is small. Now I put phenocane and the pupil has increased a little bit. Now I'm staining. This is a reasonable size. Two things are very important where the size of the pupil is concerned. One is that it should be big enough that you see a margin of the anterior capsule, which you can observe during the surgery. Another thing is that capsular contraction is real. You can see as soon as touched the lens and started the capsular axis, there was a slight movement there. It was not that bad. I'm trying to keep as close as to the pupillary margin, but I'm also leaving a little rim there, which I'll watch during the surgery. You can see I made a good rhexis and a gentle hydro, but even with a gentle hydro, uh, decompress on the other side. This lens is moving well, but as the lens is rotating, you don't have to be very aggressive here. You have to be very gentle. You can see that on the side, the capsule was moving, so I cannot take any chances. I told you that there are many surgeons who would go on and try, but you also have to look at the hardness of the nucleus. This nucleus looks hard, so we go in and place the capsular hooks. Fantastic tools, very easy to insert and apply because they have soft, blunt tips. The iris hooks also can be used. Here you can see I made a sub-incisional. This is a diamond configuration of capsular hooks because now the iris does not come into the near the incision. And now I'm placing the CTR again before the nucleotomy because I want to be sure that my support is anterior as well as equatorial. And usually when the capsular hooks are there, you don't need a bimanual insertion. The capsular tension ring goes very well and easily into the bag. Now, once that is done, again, I told you the bottle height has to come down and you have to lower your parameters. Again, this hook being sub-incisional, you could see that it doesn't cause much problem. This is a hard nucleus. I'm not trenching, actually. I'm just biting so that the central part becomes a little thin, and then I'm chopping peripherally. And you can see I'm able to achieve a good chop there. And it's very important that you do not put any unnecessary um, load on the already compromised zonules, though they have been augmented by the presence of a CTR, by the presence of a capsular hook. But even then, you are trying to keep it as low as possible. And whenever you're rotating bimanually so that the pressure on the zonules is not at one place. And obviously, a cataract like this, where you have a difficulty dividing the central part, that's why I went in and at the outset, I thinned out the central part, and that makes things much easier. Again, it's important out of my experience. I know that whenever I do pseudo exfoliation cases, whatever looks on the slit lamp, I take the nuclear hardness a little bit more than I would have estimated on a slit lamp examination. So once you crack this nucleus into smaller pieces and you have achieved a central crack also, then you again have to have a lot of patience doing these cases. There's no question of rushing through them. And another important thing is as the pieces become less and less, you have to understand an inflated bag with all the pieces inside gives more stability. But once the pieces started coming out, the stability becomes lesser. So you have to be a little cautious as the pieces go down. You put an intraocular lens and you remove the capsular hooks, and it's again at this stage when you are removing, you've done a beautiful job. When you're removing again, it's 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 very important that you reduce the bottle height while you are removing the viscoelastic. Again, a pseudo exfoliation, you see, it's at this point. It's at this point when you see the dimpling of the capsule. At that very moment, even if you have been able to pick up a phacodonosis, or you have not been able to pick up a phacodonosis, very clearly at that first step, you've already made up your mind that this is going to be tough. This capsular axis is not progressing well, and you can see a lot of movement there. And sometimes it's better to put a higher density viscoelastic, not overinflate, and then to finish the capsular axis with a forceps. Again, I'll go in and place the hooks. This is very important that we place the hooks. And again, here I only place the hooks, and as soon as I finish the nucleotomy, I understand that I can do safe cortical wash also. But at the end of it, I still place a CTR ring. So even in cases where there's uneventful surgery, nothing goes wrong, you still want to put a CTR with this hope that the possibility of capsular contraction doesn't is reduced, though literature does not tell us much about a reduced frequency. Again, when you're removing the viscoelastic, you have to be having a low bottle height and very gentle. You don't have to push down the lens. You have to be careful that it doesn't get overinflated. Again, a case reasonably well done. Like we said, the pupil has to be good. And again, another case, you can see as soon as I touch, you can see that the lens was showing some movement. And once that is done, again, I am going in and doing a gentle hydro. Uh, then here it was not planned initially. You see, I put a little viscoelastic under the capsular margin there. This makes things easier. This makes the insertion of capsular hooks much easier. I put 5 here. You can see then chop technique to reduce the. You can see we've reached the last point, but I still felt that the posterior capsule was coming up. So I'm being extra careful and I put the CTR ring before I removed the last piece. Again, when you put a CTR ring, the IA becomes difficult. Here I have again implanted a slowly opening lens. It's best that the lens goes into the bag in one go rather than to struggle. Another case, we know it's pseudo exfoliation means that they can have glaucoma also. Here we are doing a combined surgery, a phaco trap, and I know this pupil is small, so I'm already positioning my incisions and putting phenytoin, and phenytoin seems to have worked a little bit, and the pupil size has increased. So I know now I'm not putting iris hook or any pupil expander. I'm going to go ahead and straight away go to surgery. Again, this step is so important. You see, as soon as I go in, I realize that this is going to be a tough thing. So why does this capsular axis not move very well? Because there's no counter traction of the zonules. You can see I'm very slow. I'm trying to, but I can see the whole thing is moving. So from here, I know that if I go ahead, go on, you can see the movement is too uncomfortable. So I go in and I allow a capsular hook to go in before my rhexis is completed so that there's a traction on this side. And now I can have a now I can go in with the forceps and complete this rhexis. Again, cases like these, uh, you have to calculate on the table, because the on the table feel is the best feel you can have. You can always calculate preoperatively how things will go and what you should be ready for. But here, the on table feel is the best feel. And decision making in cataract surgery is a dynamic thing. You cannot get fixed to whatever you have decided. Again, a sub-incisional capsule so that I don't have a problem countering the iris also. This is very helpful. Again, I've gone in with the CTR ring first and then did the nucleotomy. And again, these cases, like I told you, they are they are much harder than you think they would be. Again, I'm using the same technique. This is not conventional trenching. It just is high power. Phaco, it just has very little flow rate and very little vacuum, and it thins out the central part. Once it thins out the central part, then you can chop so that there's a you see, in these cases, you cannot lateral separate the two segments. Once you grab them, you cannot lateral separate them too vigorously and away from each other so that the central part is cracked. So, because you don't want to laterally separate them too much. So you make these small pieces, keep them there, don't remove them, keep the bag inflated. And once that is done, you go ahead and at every step, you keep on adding viscoelastic. If you still feel that the posterior capsule might not, might because of the loose supports and zonules on the sides can come up, because this is a reality. Last piece, PC rent, is also a reality. Again, in these cases, you might have faced another problem. That's that the posterior capsule may actually get stained by trap and blue, the trap and blue going inside, and then because there's less barrier there, and once you finish that. Now let's look at this case. You saw pseudoexfoliation, hypermature cataract. I'm at the last piece. I've done a wonderful job, but as soon as I do this, you can see I have a PC rent, and bad move. I just came out, realized that I had a rent, but luckily there was no vitreous coming here, and there was a good capsular access margin. So I put a three-piece lens in the sulcus and got away with it. So that is also a reality. So we have cases where there will be frank zonular weakness. There'll be cases where you feel everything is going on, and then you have a problem during nucleotomy or any other step during the surgery. And then you have cases where everything is moving smoothly. All you might have is a lax posterior capsule. And you've done a great job, and at the end, you have a problem where you get a PC rent. I managed in this case. You can see it's nicely managed, but we have to be sure that we are ready for all eventualities and possibilities. And those eventualities and possibilities will only come if we have known about them and if we are mentally ready for them. This pupil was small, and I made a rexus before that, and then I had to put iris hooks because I thought it was small. And then once I did that, I was able to visualize the nucleus, and I did a nucleotomy. But I just want to show you here how lax the posterior capsule can be. I'm doing an IA. You please watch the posterior capsule, and this is also difficult uh, because the capsule is not firm, so we are not able to polish. You see, there's some amount of, and every time I try to polish this very low settings, the posterior capsule is coming into the, um, you can see that. That is the type of capsule we expect, um, even if sometimes we have put the CTR ring. And those people who have extra bit of zonular weakness, there obviously the approach has to be different. There have to be segments, and they have to be, this lens has to be anchored well. And thank you all for your kind attention. I always think that pseudoexfoliation is a very big challenge, and this challenge is encountered by dynamic decision making during surgery and having all the gadgetry which you would possibly need. And if it's extreme, the zonular weakness is extreme, then obviously you need some vitreoretinal support also. Thank you all for your kind attention.
Thank you so much, Dr. Sajjad sir. This was an amazing talk with so many pearls to take home. To remember to plan well for the surgery and use your equipment wisely. Make sure that your incisions to your lens implantation and even after that everything goes smoothly. I would like to invite our expert panelist, Dr. Satyajit Sinha sir, to share his comments on this, please.
I think in the beginning you said, first of all, thank you, Shivani, for the opportunity. And I would like to thank the scientific committee, Dr. Namrata Sharma, Dr. Harshul Tak. In the beginning, you said, Dr. Shivani, that he is from heaven on earth. Kashmir is a beautiful place. And I would like to add one more thing, that Dr. Sajjad himself is a very, very wonderful person. Those who have met him, they will really love to meet him again and again. So nice. And as wonderful was his presentation also. What a wonderful presentation. In between, he gave some very beautiful tips, which those who were listening carefully would have heard. One of the things was that even if you have an uneventful case, even where everything goes smoothly, still put a CTR. So that is one take-home message which was very beautifully expressed by Dr. Sajjad. It is very important to remember that this is a progressive zonulopathy. So whatever happens on the table is fine, but you have to also prepare the patient and maybe counsel, or without trying to frighten the patient, you have to let him know that this is a progressive thing and that he needs to come for follow-up regularly, at least once a year, to see that the bag is not tilting. And because we have read so many articles that the whole bag complex shifts downwards after so many years also of doing the surgery. So you have to call the patient regularly for follow-ups. And when you're doing the surgery, just like the beautiful surgeries that Dr. Sajjad was showing, our 1 point program should be that we should put the least stress on the zonules, because this is a zonulopathy which is happening. So the least stress on the zonules is most important. And he made a wonderful presentation. Thank you so much for the opportunity, Dr. Sajjad, and we look forward to seeing you in Jaipur. Thank you so much.
Satyajit, you're very kind. Thank you very much.
It's a wonderful presentation.
Thank you, Satyajit sir, for these wonderful pearls as well. I would like to invite Dr. Pankaj Sharma sir also to give some comments on this, please.
Yeah. Yes, good afternoon, everybody. I would like to thank Dr. Harshul and AIOS for giving me this opportunity. And I just echo the words by Dr. Satyajit. Dr. Sajjad is an excellent surgeon. And one thing I have learned even at this stage is putting capsular hooks after doing the CCC, which act as iris retractors also, because these pseudo exfoliation have non-dilating pupils also, And the capsular bag itself, the zonules are weak. The bag is a bit mobile. So it's an excellent thought because it is said that you should put iris hooks before doing the CCC, but here we should do the CCC and use capsular hooks so that they act as a bit of iris retractor also, and they stabilize the bag. And as rightly said by Dr. Sachidin, the capsular tension ring is a must for all these cases, because after sometimes you might have a totally lost bag IOL complex in the vitreous after even after a few years. So follow-up is extremely important. And these patients also have some endotheliopathy. So the OVD which we use, it has to be of top quality. We should avoid use HPMC on or other such low-grade OVDs. We should use chondroitin sulfate and hyaluronic acid-based OVDs, and which give so much of stability to the anterior chamber. And also, God forbid, if there is some dialysis or some rent, the chondroitin sulfate-based OVDs will have a capsular bandaged thing. It will tamponade the vitreous from coming up. So always we should remember that we should use a very good quality OVD in all such cases, not just to protect the endothelium and the iris, but also to have a bandaging effect on the places where the zonules are lax, or if there is a rent. And also, one more thing is putting a ring. We can use, now we have injector systems. Sometimes when we are injecting the ring itself is so large that it causes equatorial traction on the opposite side. The zonules may break. So the best way to put a ring is to inject the ring into the bag with an injector, which causes least stress on these zonules. So I think all the other things have been wonderfully covered, and I don't think I can add anything much more. Thank you so much. Thank you.
Thank you, sir. Thank you so much for these tips. These help us in our everyday practice, and as well as PG students to know what they are supposed to look for in a patient with pseudoexfoliation. Also, I would like to now ask a question to Dr. Lalwani, sir. What exactly does pseudoexfoliation influence your IOL selection strategy or your IOL fixation strategy in patients? I would really love to know.
Good afternoon, everybody. So IOL selection depend upon the how you are dealing with the jonular. First, you have to do preoperative checkups, jonular weakness, and if any lens is decentered, iridodonosis and phacodonosis is there. And if you are dealing with a jonular dehiscence in 1 or 2 quarter, so I should not put any multifocals or EDOF lenses. And as per toric IOL, I also worried about the toric placement and centration. So if jonules and if CTR is well placed, then I will put toric lenses, otherwise not. You are asking about the material, hydrophobic lenses or something else, Dr. Shivani?
No, sir. The choice of lens exactly, because if we are seeing, as you correctly said, if we are seeing any obvious zonular dialysis, then we always think of first, if the pupil is not dilating well, then pupil expanders, then CTR, and then lens. So if already there is zonular weakness, would you prefer a three-piece or a one-piece? My question was in that line.
Multi-piece lenses, if bag is weak bag with the help of TR ring, then we can put a single piece hydrophobic lens. We don't need multi-piece lens.
I think as a rule in these pseudoexfoliation cases, we put a simple monofocal lens because these bags can get decentered, these bags can move, and then the trifocal and the multifocal lenses, they make life more difficult for this patient. So monofocal lens is the the best thing to be putting in these patients who you suspect pseudoexfoliation?
Yes, I totally
So
agree.
in cases,
Definitely.
sorry,
I
please.
Yes.
also agree with you.
And just one more point, I think very well suggested by Dr. Sajjad is the initiation of the CCC. The initiation will give you a clue how much lax the zonules is, how much unstable the bag is, and then you can make your clinical judgment. But I totally agree with Dr. Sachidit, sir, that we should avoid using multifocal or toric because down the line they might get decentered, and then to deal with that will be a big problem. And as for far as possible, we should use the aspheric neutral IOL so that the decentration will cause least amount of change in the optical quality. Whereas the negatively aspheric lenses, even slight decentration can degrade their qualities. We should choose the aspheric neutral IOLs in these cases, monofocal.
Can I
So,
add?
Sir, I've
Toric, I
also
think we
seen
can
in some
do
patients
medium plus
that they put a, sorry, ma'am, please.
yeah, no, agree with everything that is being said, but I think toric are very forgiving. So if there is a lot of astigmatism and the bag is kind of stable and you got away with your phaco, and you can do a toric.
Yes.
Toric, I think, can be done.
Ma'am, can I add
So I
some?
think
Can
somebody
I
has
add?
written
Yes.
in the chat also. Yes, please.
See,
Yes,
Dr.
sir. Ellen, please.
Dr. Shivani's question was, can we, it's between a three-piece IOL and a single-piece IOL, if I could understand properly. Best in case of progressive dialysis, progressive damage to the weakening of the zonules, best is to put a CTR inside the bag, place a three-piece lens in the sulcus, and lock the haptic. What is the advantage of this? So that if there is a posterior dislocation, this placement in the sulcus will hold the capsule and it will not get dislocated. If that chance is there, it's better always to put a three-piece IOL. And like I agree with everyone else, if the
So
bag is
three piece in
stable
the
or in,
bag is so three piece in the bag. Is that also an option in cases where we have a zonulopathy of 4 to 5 clock hours and we have already put a CTR?
yes,
So if you put
three,
the three piece in the bag, so will it give more
No,
stabilization with the,
not
what
no,
only
is the
stabilization,
expert
but the
no.
opinions?
No, stabilization we have already achieved with a CTR. If it is not happening with a CTR, an additional lens will not help it, but we need to stabilize the bag with a suture. That is a CTS or a modified Sioni ring. The
CTS, yes.
only way, three-piece lens is definitely more stable than a single-piece lens, let's accept that. But that will not add any extra advantage over a CTR. If it has to add an extra advantage, it should be in the sulcus with the haptic optic capture in the capsular axis.
Agreed to it, sir. So with this, we move on to our next speaker. I'm just going to quickly share my screen to introduce our next speaker. So our next speaker is Dr. Ellen Kumaran Pasupati, sir. He is currently the medical director of Navashakti Nethralaya, Bangalore, and he is also the present secretary of president of Bangalore Ophthalmological Society and the joint secretary of Karnataka Ophthalmological Society and the joint treasurer for All India Ophthalmological Society. He is also the past secretary of Bangalore Ophthalmological Society and Karnataka Ophthalmological Society. He was the scientific chairperson and the editor general. He has got the gold medal from Bombay Ophthalmological Society, Bombay Ophthalmic Academy to 2023, and the gold medal of IIRSI in 2023. So I hand over the podium to Sir to introduce, to give his talk on hydrogenic glomerular dialysis.
Thank you, Dr. Shivani, Dr.
Over to
Sunil.
you, Ellen Kumaran, sir.
Thank you. Is my screen visible? Hello, is my screen
Yes,
visible?
sir. Yes,
Yes, sir.
yes,
Yes.
sir. Yes.
Thank you, Dr. Shivani. Thank you, Dr. Sunandini. I also want to thank my teacher, Dr. Namrata Sharma, and my dear friend, Dr. Harshul Tuk, for this opportunity. Now, these cases are slightly different. This is a compilation of 4 different cases of iatrogenic intraoperative dialysis. All the cases were done by me. I only induced on how I'm managing. Not all cases go on well. This was a case that was going on very well. Suddenly, this happens. I've gone to the periphery, got hold of the capsule and pulled it. These were cases with no zonular deficiency noted earlier, but then I have induced this. How do we manage this? Most important, we would have noticed only the side port is removed. The irrigating port, that is a phaco handpiece, is retained there and viscoelastic is injected. That is the viscofluid exchange, and only after that the irrigation has to be removed. Then we create a space between the lens, that is whatever lens available, and then capsule, insert a CTR. Again, insertion of a CTR, there are various methods, and resort to what is called as slow motion phaco emulsification. You can see this is actually the real-time video. All other parts I have fast forwarded it. Each of these surgery, even after editing, will be around 15-20 minutes. Can't cover it in 8 to 10 minutes. So I have fast forward most part, but the important parts I'm showing. This is slow motion phacoemulsification. Slow to rotate, if possible, better not to rotate, but this is a small zonular dialysis, less than 3 clock hours. The point here is to separate the nucleus into small pieces. Instead of 4 or 6, we can make it 8 or more. Without any pressure on the bag, on the zonules, bring it to the pupillary level and then emulsify it. That's what I've been doing throughout this case. Luckily, nothing more happened. The CTR is holding on. Again, last piece, as elucidated by my previous speaker, be very careful. Though the CTR is there, sometimes mishaps can happen. You can't have two different complications in the same case. Again, while removing the cortex, be very slow. You can see the speed at which it is being removed. Instead of centripetal pulling, please pull it tangentially so that the tangentially and towards the area of zonular dialysis. This was the area of zonular dialysis, what we had created. Always you will see that the cortex I'm removing, I'm pushing it towards the area of zonular dialysis and removing it. Make sure any time whenever you change, go in for a visco fluid exchange. Never allow this chamber to collapse. Then slow movements towards the area of zonular dialysis, and then the final cortical matter is removed. Most of the cases, again, viscofluid exchange, most of the cases I do a hydroimplantation, but in these cases, hydroimplantation is to be avoided. Viscoimplantation of the lens, rotate the lens so that an additional help in the form of the haptics is obtained, haptics to be placed in the area of zonular dialysis. Now again, the question comes, which lens is better? Should it be the 3-piece IOL in the sulcus, or should it be a single piece lens like this? Again, towards the end, make sure that you you maintain the AC, that is hydrate the port and then you finish it. We'll again answer that question later. This is another case which I thought was going very well. It was fast, had planned her for an advanced monofocal IOL, and I'm doing the Rosettelli's wedge removal. That's what I'm doing in this case. Everything went on well, and I was quite happy. You can see that it is an uncomplicated wedge removal. Made it into 6 pieces. Normally that's what I do, either 4 or 6 pieces. If I'm using this method, hard catheters, I go for a direct chunk. And everything was fine. So I thought I've got away. But then irrigation aspiration started. And then you can see what's going to happen now. Now I go there, hold it. The entire bag has come into my irrigation handpiece. Luckily, less than 90 degree. If such a thing happens, make sure that you release the bag, retain the irrigation port inside, withdraw only the second port. I thought of trying something. I thought I can still remove the cortical matter in the rest of the places. But then I realized that it's not good to continue, that too when a premium IOL is being planned. So slowly I withdrew the aspiration handpiece, filled in with viscoelastic viscofluid exchange, inserted a CTR. Again, there are various ways. Create space, insert a CTR. Bimanual is always the best, but whatever you're comfortable with. Again, injection method, if it is available, is again has less problems. But always, like my previous speaker said, make sure that you do not create an equatorial puncture. I did that also in another case. So make sure you don't create an puncture. Again, I'm showing the islets of the CTR are somewhere here. Zonular dialysis is here. Make sure that you push the cortex towards the area of dialysis so that you do not induce extra dialysis. Once the CTR goes in, it's really difficult to tease out this cortical matter. So patience, slow motion, tangential pull, and maintaining the chamber always matters. Now, this is the lens. This is one place where it could be questioned because these advanced monofocal lenses are aberration dependent. So, by chance, the patient gets more of a displacement that's going to create trouble. Definitely, yes, I agree to the point. But we should also remember these are dialysis that I have created. Most of these patients were perfectly normal. Now, these are two cases where I said how to do it. Now, this is the third and fourth case. I'll be showing what not to do, at least one step of what not to do. Again, case going on very well, patient quite uncooperative. Moves his eye, I follow it in that speed. This has been slowed down a little bit. And then I bring in the capsule with a chopper. So again, the pulling out of the handpiece should not be done. Luckily, I got away in this case. Always remember to hold that handpiece there, fill in the viscoelastic through the side port, and then withdraw the handpiece. This has to be done. Luckily, in this case, nothing major happened, no vitreous loss, no further increase in the dialysis. Somehow managed to finish this case, but this I show this only to say what should not be done in these cases. If the cortical matter can also be removed after placing the IOL inside, again you'll notice all these IOLs, the haptic is placed in the direction of the dialysis. Some amount of cortical matter, if it is not coming out, can be left behind. We can yag it later. No egos here to remove everything outside. Again, got away again in this case. The last case is a very old case, maybe 15, 20 years. You can see that during the lens, I've encountered a dialysis. So the video starts at this stage. Of course, a very long video. It has been edited. IOL has been removed again. I'm using the main port for a vitrectomy. Those were days triamcinolone acetonide was not yet unheard of in the thing. But the main port should not be used for vitrectomy. In these cases, it should be a smaller port. And you can see that I'm placing a Sioni ring, and any dialysis in the area of your main port is the biggest headache to suture. Somehow we manage. Those days we used to use 90-Prolene. Nowadays, if a similar case happens, we use 60-Prolene and flange it. Thank you for the opportunity provided.
Thank you so much, sir, for this wonderful talk. I think we have learned a lot on how to avoid these complications and even if they're happening, how to manage them. So, I wanted to take the expert panel's opinion. We'll start with Dr. Pankaj Sharma, sir.
Yes.
So, what do you think that in residence ad or in early days of our phacoemulsification, what is the first maneuvers that causes this iatrogenic zonular dialysis in this uneventful cases where previously there was no.
See, I teach all my PG students, and when they pass out from here, they start doing independent phaco. But the first step I teach them is to use the phaco in one hand. Don't do anything by manual, because to coordinate two hands in the eye, it is difficult to coordinate one hand, and sometimes when they take the phaco inside, the eye rotates to the other side. So I teach them how to keep the eye in the central position with only one instrument in the eye. And then I teach them how to sculpt. Now, when you put the other instrument in the eye, then everything goes haywire, because when they are learning what they are doing with with one hand, they forget what the other hand is doing. So there it causes problems. And the second point where the usual place where the dialysis occurs is when they do lateral separation after making the trench. So I always ask them to be very careful, or mostly I ask them to withdraw all the instrument, put a viscoelastic, and then take two instruments inside and gently separate. Don't try to separate with one needle of the phaco and the other a chopper or a hook. So always I ask them to, because they are in a heightened stage of anxiety at that time. So I always ask them to make the trench, bring the things out, put some visco in so that their anxiety level also goes down, and then they take two instruments and they go then they go inside. Now the third place where the dialysis occurs is if they start to learn to chop. Exactly, they have to know where the CCC edge is so that they don't catch hold of the CCC edge and cause the dialysis. And then lastly is the IA. During IA, again, they might catch hold of the uh, capsule. Now, just at the CCC edge, it is not easy to catch the anterior capsule. If you go under the capsule and up to the equator, then the capsule there is a bit lax. That can come along with the IA handpiece. So these are the few places how the dialysis can occur. One thing I saw in the video which was just shown is if the cortical matter is too much inside the eye and the dialysis occurs, then before putting a ring, I think we should use two or three capsular hooks to tent up that area and then remove the cortex. Once the cortex is removed, and then we can inject the CTR inside the eye. Because the CTR inside the eye with lot of cortex, it becomes very tough to remove the cortex once the CCC, the capsular tension ring is inside. So at that point, I think a capsule, two or three capsular hooks in the area of the dialysis would help more to clean the cortex better, and then afterwards, then the CTR can be put inside.
Thank you so much, sir. I think with this, we understand that line that everybody always says that CTR at the last, till the time you can avoid putting the CTR, I think you should avoid it. So my next question will be to Dr. Dilip Lalwani, sir. Sir, matlab, if you can, summarize for our viewers that when should we put a CTR, when we should put a CTS, or when we should, do something else. If you can just summarize for us in any iatrogenic glomerular dialysis cases.
Thank you. First of all, any case of pseudoexfoliation, I usually take it as a high risk cases, and I prepare CTR iris hooks or send my OT so that I take it as a high risk cases. First of all, you don't need to say that without CTR I will do. So you have to prepare for yourself that it will have a jonular dehiscence anywhere, and if only pigments or flax in the anterior capsule is there and well centered, no phacodonosis, no iridodonosis is visible, then we can think without CTR. Otherwise, you have to put CTR in all the cases. And I agree with Dr. Pankaj Sharma sir also that heterogenic capsule or dehiscence or jonular dialysis you have to take care of during IA also. In these cases, you have to fill with the visco well so that you cannot pick the capsule in the area, in any area. So you have to IA slow and with a visco field. So, and CTR is I think, and Dr. Satyajit Sinha is also told this is a progressive zonulopathy. So if you are avoiding CTR at that time, But in the coming future, if there is a phimosis or gradular zonular dehiscence will be there, your lens will definitely fall with the bag. So I think we should put 99% cases in CTR. So this is my take home.
Thank you so much, sir. And yes, sir, please. Dr. Sajid, you wanted to add something, sir, please.
I just wanted to add something. So I agree with you that the implantation of the CTR should be delayed to as much as safely possible. As much as safely possible. So in pseudoexfoliation, you would want not to deferrate lest a serious problem occurs. But if we're talking about iatrogenic, rest of the zonules are very strong. So we know that we have a choice there, and it depends upon the surgical expertise of the surgeon whether he's able to clear or not. The only problem with putting CTR when there's a lot of cortical matter there is the difficulty. So normally also we say when we are doing IA, cortical cleanup, the whole thing should be done not directly pulling it towards the center,
Stripping motion.
yeah, that puts a lot of
Sweeping motion.
normal. Yeah, it has to be. So here the CTR ring is there. So we have to tease these fibers off, literally off the equator, and
Yeah.
tease in such a way that sometimes we even see the CTR, coming up as the cortical fibers are gone. But apart from that problem, I think it is safer to err on the side where the CTR is placed, especially in pseudoexfoliation earlier.
Thank you so much, sir. Dr. Satyajit, sir, your take on this, and I have one more question from a panelist, from one of the delegate, that sometimes what happens, we put viscoelastic and the zonular dialysis or the PCR extends. So how they should understand that how much visco or how much AC maintenance is needed in these cases to avoid the further damage?
I think first of all, uh, Dr. Pankaj gave a good suggestion that these cases are more prone to endothelial cell loss. So we should use a high viscoelastic in all these cases. And once there is zonular dialysis, then like Dr. Ellen showed some wonderful videos. Dr. Ellen, my big congratulations and deep appreciation for the wonderful videos that you have shown. Very nice. And how you have managed it is even better. So Dr. Ellen has shown very nicely of when you should put the CTRs and when you should put the hooks. At some point of time, like Dr. Dilip Lalwani was saying, that if you see that there's a zonular dialysis happening, then you put the hooks first and then put the CTR, then that will make things much more comfortable when you're removing all the remnant cortex which is there and then put the IUL. And one of the suggestions which Dr. Ellen gave was, is the perfect solution, that put the IUL in the sulcus, a three-piece IUL, and do a optic capture. That will help stabilizing the bag also, and the IUL also will be there for a much longer time than if you had put it in the bag and there will be progressive zonulopathy happening. So if the lens is in the sulcus, like Dr. Allen said, that will be perfect.
Thank you so much, sir. With this, I hand over the podium to Dr. Shivani Patnaik to invite our next speaker, please. You're on mute, Dr. Shivani.
Am I audible now?
Yes, yes, yes.
Thank you so much, Dr. Sunandini. I'm very glad that I'm a part of this session because we have a pseudoexfoliation case slated next week on Tuesday. So I'm going to take all these first and I'm going to ace it, I think. I hope. So one small question right before we dive into the next session is that what exactly would you tell this patient? How do you counsel this patient for the future that your lens can get dislocated later in the future? What if he just cancels surgery and runs away on Tuesday? What do I do? So what can I tell him or her that this particular lens or this particular surgery has been chosen by you? They put a lot of faith in us and they don't want to hear us telling them all the cons of the surgery. They want to hear only the pros. And as we know, patient doesn't care what kind of complications there are. You're the surgeon. You're supposed to give them 6, 6, and 6, no matter what. Of course, N6 has been counseled about with glasses, but the rest of it, how do we tell the patient that don't worry, you're going to be safe, without saying that we are God, we'll take care of everything.
Seconding your question, Dr. Shivani, in one of the conferences, I asked the panel which was sitting there that we already have evidence that the bag can get displaced. So can the patient take you to a consumer court that you knew that one day my bag may or may not fall? So why didn't you put a scleral fixated IUL to begin with, rather than trying all these things of putting, because you knew this is a progressive zonulopathy, there is no more science remaining to be learned about that. But it's very difficult to say in which case this will happen or not happen. So it's a good idea to tell the patient, like I said in the beginning, that a regular follow-up is important. And if you just slightly tell them, not scare them out that your bag will fall down and your lens will get displaced, but if you tell them that you have to come for regular follow-ups, and that sometimes in some cases it has been seen that a slight displacement happens, then they will be mentally, they will have it in their back of their mind that they should come for regular follow-ups. And God forbid, if something happens, if there is a little tilting or there is back displacement, they would have something in their mind कि हाँ डॉक्टर साहब ने कहा था कि ऐसा कुछ हो सकता है. So without scaring the patient, just telling them that to come for regular follow-ups is important, and that some slight displacement may or may not happen over a few years. So that will be enough to tell the patient without scaring him. That is my take. And then my answer to the panel remained unquestioned. Whether the patient could take you to the consumer court that you knew that this bag may get displaced, but still you didn't put an SF IUL and you have put in the bag IUL. But that is something that remains to be still learned. We still have to learn so much that whose zonulopathy will actually progress beyond within his lifetime, and in whose it will not, is something we still have to learn.
It's easier
Thank you
confronting.
so much.
It's
Sorry.
easier confronting believers. Believers, you can bring in the concept of destiny and fate. Anyway, here it's very important that we can ask for a good follow-up also, because many patients are going to have glaucoma or already have glaucoma. So you tell them that you need to have a regular follow-up for glaucoma. I told you that capsular contraction is a reality in these patients, especially if your pupillary size was not that big. So you've left more anterior capsule. Let's say and as the capsule contracts, the zonules are pulled to one side. So that's how it starts basically. So if you're following up a patient regularly, like Dr. Satyajit said, that you are watching it, dilating the pupils, seeing how much, sometimes small relaxing YAG capsulotomies in the anterior capsule go a long way in preventing capsular contraction. So follow-up is definitely very, very important.
Thank you, Dr. Sajjad. Thank you, the panelists. I would like to now introduce our next speaker. I'm sharing my screen. So we would like to invite Dr. Rakesh Shakya sir from Sadguru Netra Chikitsalaya, the Mecca of cataract surgery. I've had the opportunity to observe there for a couple of months before starting my residency, and it was an eye-opening experience to say the least. He's a proficient surgeon. My words fall short. He has performed more than 1 lakh cataract surgeries and 15,000 glaucoma and other surgeries. He has received the Presidential Gold Medal Award in the field of ophthalmology by the Karnataka Ophthalmic Society, Udupi, and the Top Video Award in the anterior segment, AIOS, and many other laurels at Best Poster and Best Award segment in the posterior segment also in 2023. I would like to invite Dr. Rakesh sir to share on pseudoexfoliation and cataract with us, so that even I can benefit on Tuesday from my surgery. Thank you.
So thank you, ma'am, and thank you, Sir Harshal Tak, and especially Namrata Mehta to give the opportunity. And so I am going to directly. So my screen is visible.
My screen
Yes,
is
sir.
Your
visible.
screen
Yes,
is
sir.
visible.
Yes, sir. Yes, sir.
Yeah. So actually, everything is covered nicely. Everything as I am going to actually demonstrate the one more technique to actually demonstrate how to do the cataract surgery in the pseudo exfoliation. Because despite of the many techniques and technology, pseudo exfoliation have the some challenges. So this is just the case is the slightly much dilated about the 7 mm people, and so this is the mild seed exfoliation. The patient was actually it is around 70-year-old male, and initially we can see there are the some mild general weakness, but the pupil is dilated properly. So in this case, actually, I am going gently hydrodissection in this case properly, and then after that, just I prolapse the nucleus. Actually, I demonstrated the Phaco prolapse method in this case. So, and just I prolapse the one pole of the nucleus out of the bag, and so actually I to plan the without actually sculpting. So we can actually keep the nucleus out of the bag. So the half of the nucleus at the level of iris plane, and then without sculpting, you can do the direct crack of the nucleus, and then crack the side piece again with the help of the Sinsky or chopper like that, and then we have another 2 3 pieces. So the anterior half of the nucleus become totally cracked, and after that we emulsify the nucleus with the minimal energy, and you can put the copious amount of the bisco before that, and when the half of the nucleus is emulsified, the automatically the other half of the nucleus comes at the level of iris plane, and then you can chop very easily and emulsify very easily. After that, you go very gently removal of the cortical matter with the tangential, just as you mentioned in the earlier speaker, and do the slightly polishing also, and then put the oil in the bag. But this phaco prolapse method actually we always given the two when the cataract is the pupil is slightly dilated or cataract grade about a 2 or 3, and sometimes when the cataract actually slightly harder, more grade, like grade 4 and 5. So another case actually I show you. So this is the case is actually the grade 5 cataract, and the people is around 5 mm, and the people is actually slightly raised. And so I try to, with the help of the coagulant hooks, initially I just pupil become slightly flexible. And after that, we do the staining of the capsule in this case, and then put the copious amount of the bisco, but the pupil is not much dilated in this case. So I'm doing the surgery in the slightly in a zoom. So and then I put the in this case I put the BHEX ring. So this ring also has very flexible ring. I always use this is the ring made by the Sri Bhattacharya. In this is the Indian rings, and this rings has the six actually properly dilated about the 5.5 or to 6.5, and pupil is dilated, so the all flanges is engaged properly. After that, with the help of the Sinsky, so after 60 tom, I just initiate the rexes in this case, and then with the help of Atrata force I try to make a slightly bigger rexes around 5.5 or 5 mm, and then go very gently to the hydrodissection in this case, because the journal actually weakness there. So by this region, I put the CTR in this stage manually with the help of the MacPherson forceps, and then I take the Sims cube to actually dive the CTR in the bag. So after that, job becomes slightly easier. The nucleus is rotated properly, and then I actually nucleus slightly harder, so you can make a slightly deep trench, go very slowly, and then crack the nucleus, and then not much stage the nucleus, and then rotate the other half of other side, and then crack again. So don't crack in the only one side. So you crack the nucleus from the both sides, so you can actually get the less stage on the nodule. After that, when the one piece of the nucleus is emulsified first, so the rest of the part of the nucleus then emulsify one by one, crack and emulsify. So I always actually use this technique. And then after emulsification of the all pieces, and go very gently to remove the cataract or cortical matter, very gently, because the CTR is there. So the actually sometimes the jonular dialysis also occur during the IA. So after that, the cleaning of this cortical matter, put the visco again, so inflate the bag and put the oil in the bag. So when the oil is actually totally in the bag, and then put the visco again. After that, we remove this BHEX ring in the all sides, and then remove it. And you can see the pupil is almost same as we see in the preoperatively. So this is actually the slightly advantage. But when you use the iris hook, so this Gupta also very good. So thank you so much actually. So thank you so much to give the opportunity to present my two cases, because another speaker actually said that the about the pre-operative, but as the sir is say, the post-operative care is very important, because the chances of the inflammation is very high in this case, in the pseudoexfoliation and the glaucoma. So it is required the more steroid steroid eye drop to actually reduce the inflammation also. So when you operating this type of challenging cases, you have to actually keep the SIC set, small incision set, in the side of the table and vitrectomy unit, because the chances of the complications slightly higher. So the when the nucleus goes slightly in the down, you have to convert it. So actually you don't hesitate to convert in this type cases, and go for the secondary IL implantation like scleral fixasis IL. So thank you so much.
Thank you so much, Dr. Shakya sir, for this amazing talk, and all the demonstrations and the well thought out and well planned surgeries lead us to good post-operative results, and keeps our expectations and the patient's expectations also realistic. I would like to invite Dr. Shekha ma'am to tell us if there is one non-negotiable rule to be followed in such cases, what would it be? Is ma'am with us? Okay, I would like to invite Dr. Ilan Kumaran sir to please enlighten us on that topic. Is there any one non-negotiable rule, sir, that you follow, that in this particular surgery, at this particular step, I'm supposed to do 1, 2, 3, 4? These are the points or pearls that helps us. Can you please elaborate, sir?
If there is one rule, there's definitely not one rule, multiple rules. But if there's one rule I have to prefer, I'll make sure that I don't put any extra stress on the zonules. Beautifully shown by Dr. Rakesh. He did a small rhexis because the pupil was less, inserted the BHEX ring, enlarged the rhexis. Beautifully shown. Number one, take care that your rhexis is adequate, not too large, not too, definitely not too small. That is first one. All the things what we are doing is to make sure that there is no extra stress on the zonules. Second, when you are doing the phacoemulsification, beautifully shown by Dr. Sajjad, debulk the central nucleus if it is hard. If not, also divide it into multiple pieces and then bring it out. Do your pupillary phacoemulsification in the pupillary plane. Third, again beautifully elucidated by all the speakers, make sure that you do not put any kind of centripetal pull. As much as possible, the swinging motions, the tangential motions are better in these cases. And in case of a doubt, definitely CTR is better, though there is a very large study by Aravind which says whether you use a CTR or you don't use a CTR, in cases of pseudoexfoliation syndrome, the results are same. Yes, that study is very good, but in private practice, it's better we put in a CTR so that if there is any small subluxation, we can always pass a 60 prolene there, flange it and hold it. That is one method. I did it for one of my cases. So CTR will help because most of our single piece lenses, the haptic, we cannot use that. And again, maintain the chamber at all cost. These are the things, but all these are directed towards one point, no stress on the zonules.
That's so informative, sir. Yes. Dr. Pankaj, sir, is there any rule that you follow as far as CTR timing is concerned? It remains a little controversial. What guides your choice? At what step would you like to insert the CTR, or is it case dependent for you, sir?
See, just like exactly what Dr. Sajjad had said, if it's a progressive zonular disease like pseudoexfoliation, we should put the CTR at the beginning after completing the CCC only, because all the other maneuvers will be jeopardized. Your Phaco, your lateral separation will all put stress on the zonule. So CTR has to be put initially only. If it is a small iatrogenic zonal dialysis, then it is better to keep capsular tension hooks in that area of localized dialysis, then remove all the cortex, and then finally put the CTR in the end. But if the all the zonules are weak because of some disease in the zonule, CTR has to be put initially just after completing the CCC. One more thing, when you're doing the chopping, there are actually two types of chop. One is the horizontal chop and one is the vertical chop. The horizontal chop always gives more stress on the zonules equatorially. So try to learn and try to do an vertical chop right in the center, because then the nucleus separates from the center to the periphery. When you're doing a horizontal chop, you're bringing the chopper from the periphery to the center. So more chances of catching hold of the capsule because the pupil is not dilated. Secondly, the motion of separating from periphery to the center will put more stress on the zoning. So always we should try to do a vertical chop in such cases to minimize the stress on the zonules.
Thank you, sir. Thank you for these thoughts on this topic. And another question that I had was, what is the first indication during the surgery that tells us that this case is going to go haywire? Or what is that red flag that is the most important thing to consider before you say that let us maybe go another way or plan the surgery differently?
So one is the pre-op assessment itself. If you see the slightest amount of phacodonesis pre-operatively, it's the biggest red flag, which means that now that you will have to plan like a subluxated cataract. And second is, like Dr. Sajjad rightly said, the initiation of the CCC. At that time, because you are tugging on the CCC, you get a real-time feel on how tough the zonules are, how much lax they are, and your movement will guide you as to what should be the step afterwards. And thirdly is actually, if something goes wrong, I always teach my students to recognize the complication. The management of any complication is to recognize the complication as early as possible. That is the first step. As soon as you get that the dialysis, suddenly there is a give way. You might have a pupillary snap. You might see a good glow from one of the edges of the lens, and suddenly the the dynamics will change. You will the nucleus will not rotate freely, and aspiration will not occur so effectively. So as soon as you fear that something has happened, immediately you should call your senior, or you yourself should be very careful and do not remove all the instruments in a jerk. So just assess the situation, remove the side port, and inject a good viscoelastic, and gently then remove the phaco needle. So the presence of mind is most important in such cases, and to prevent further iatrogenic complications.
Thank you, sir. Thank you so much for such a rich discussion. Each and every point, each and every topic that was put across with video demonstrations has made this course so much more informative and so much more, many pearls to take home and to implement it directly in your practice. And also, such basic things were shared which are so ignored and maybe missed out in this Pandora's box of a case, which is pseudo exfoliation. I would like to invite Dr. Harshul sir for his comments now.
Yeah, thank you
Thank you,
so much.
Dr. Sunandini. Thank you, Dr. Shivani.
Yeah,
Thank
thank you
you,
so
sir.
much
Thank you, sir.
to
Thank
both
you.
of you. And I'm really grateful to all the speakers, Dr. Rakesh Akia, Dr. Sajjad Fazili, Dr. Ellen Kumar, and Dr. Shivani for the wonderful talks, to all the expert panel for sharing their insights about this difficult topic. And thanks to the entire AI scientific committee. And with this, I'll invite all of you for the next module, that is module 8 on Wednesday. That's a very important module on Phaco in post-refractive surgery eyes. What are the challenges in biometry? What are the challenges in post-RK patient, post-LASIK patients? Because those patients are now increasing, and every practitioner is getting those patients too. So how to get best result in those kind of patients will tackle in the next module. So I'll invite all of you for that. Thank you so much, everyone, for joining. And I
Thank you,
think
everybody.
the questionnaire and for assessment has been posted. I'll request all the attendees to take that questionnaire and assessment so that we can generate certificate for the same.
Thank you, Dr.
Thanks to
Harshil,
each
for
and
the
everyone
opportunity.
again.
Thank you.
Thank
Thank
you
you,
so
Dr.
much, sir.
Shivani
Thank you.
and
Thank
Dr.
you.
Sunandini, so much.
Thank
Thank
you
you.
so
Thank
much,
you,
sir.
everybody.
Thank you.
Thank you to all
Thank
the
you.
panelists and Dr.
Bye.
Sunandini as well. Thank you.
Bye.